All right, and Dr. Abramson should be right back with us. I guess he's having some technical issues on his end, and we're bringing him back in. There he is. All right. When that happens to you, Dr. Abramson, everyone thinks, so someone's invading the conference to block you from speaking. I think you might be muted because I can't hear you.
Am I
There you
muted
go. You're,
now?
you're, you're good.
Okay, now to
And
share screen again.
yeah, you need to share it again, and I'll confirm with you that it's shared properly.
Okay.
Uh,
What makes you think that that's not the case, Michael?
well, I don't know. I don't know. All right.
Anyway,
Thank-
that was sort of inhuman. Um, anyway, I'm walking out of this medical meeting with this high-ranking but not chief editor of a very prominent medical journal, and I asked him, "Why don't you just require that the clinical study report be submitted? It's already produced. It's not going to cost any money. If there's any secrets about manufacturing anything, you can redact that, and then your peer reviewers could look at the real data." And before we took the next step together as we were walking out of this meeting, he said it would be a death spiral for the journal. And what he meant is exactly what's on this slide, that JAMA did that. They went a step further than the clinical study report. They said the actual data has to be reviewed. But what happened is that the large clinical trials stopped being submitted to JAMA, and they went to the number of trials that were submitted to the Lancet and the New England Journal increased proportionately. And any trial that does this, any journal that requires data to be submitted on their own is going to voluntarily enter a death spiral, because the big articles that sell reprints and make money and create an impact factor aren't going to come their way. So there was a movement afoot after the JAMA changed its policy to have all the journals work in consort to require data transparency, so that no individual journal that decided to do the right thing would be hurt. And unfortunately, the oops, um, the result of that, written up in stat, was that the fruit that was born was like that ice cream cone, which was in the article. New science data sharing rules are 2 scoops of disappointment. What they mean is, I put the language from the article there, but what it means is, not only did the International Committee of Medical Journal Editors, 13 editors of the major general medical journals in the world, not only did they not require data transparency, but they kicked the ball so far down the field that all they require is a statement about what they're going to share. So, for example, in the article they published about the Alzheimer's drug Leqembi, which we don't have time to talk about today, but looks like it produces a statistically significant slowing of early Alzheimer's, but not a clinically significant slowing of early Alzheimer's. And if you want to know more about that, we can talk about it in the questions. But when you look at the New England Journal of Medicine's website, they published the article that said there's a statistically significant slowing of Alzheimer's disease. And you go into the bowels of that article and look at the supplemental data and look at the data sharing agreement. They stated what their data sharing policy will be. They won't share data. And that fulfilled the requirement that the International Committee of Medical Journal Editors implemented to state your data sharing policies. Now we get to clinical practice guidelines. These doctors have to follow clinical practice guidelines. It's supposed to be the best evidence-based medicine. And if they don't follow those guidelines, the guidelines are presentable in malpractice cases. But they have no access. The guidelines also, like the peer reviewers for the medical journals, they have no access to patient level data, and they have financial conflicts of interest. So the Institute of Medicine was noting that these financial conflicts of interest were couldn't be stamped out, and they had written for about 20 years that something needed to be done about it. And finally, the Institute of Medicine made a recommendation to the National Guideline Clearinghouse indicating the extent of adherence. The Institute of Medicine called for a statement indicating the extent of adherence to the guidelines for guidelines. The Agency for Healthcare Research and Quality, which is in the federal government, should require the National Guideline Clearinghouse, which was the go-to site for clinical practice guidelines. They were getting 200,000 hits a month, to provide a clear indication of the extent to which clinical practice guidelines submitted adhere to the standards of trustworthiness. And when will the National Guideline Clearinghouse implement this? In October of 2017. So this is a major step forward for doctors to be able to go to the National Guideline Clearinghouse and to get not only the guideline, but an independent assessment of how trustworthy the guideline is based on their adherence to the guidelines for guidelines. But this appeared above that statement soon thereafter. And it's the Agency for Healthcare Research and Quality National Guideline Clearinghouse website. It's going to be implemented in October 2007. The website will not be available after July 16th, 2018, because federal funding through the AHRQ will no longer be available. In other words, the AHRQ and the National Guideline Clearinghouse was going to take this matter into its own hands and require a statement of trustworthiness that would warn doctors or inform doctors about the trustworthiness of guidelines, and it was zero funded. The government zero funded it, and doctors do not have access to that website or to the independent oversight of it. Now, controlling the U.S. is controlling the price of drugs. We are alone in allowing drug makers unlimited opportunity to exploit their monopolies on new drugs. Let me explain that a little bit. A monopoly is the monopolies they have is the result of the patents that they are granted. When they get a patent, it usually provides at least 9 years for regular drugs and 13 years for biotech drugs, where the drug company alone can market the drug under the brand name of the new drug. So when they have a new drug they claim that virtually all of the new drugs have unique benefits, although we just saw that only 25% do, but their marketing pays off because when they market the brand name of their drug, that's their drug. They have a monopoly on it. And as you all are probably aware, there's a new plan in the Inflation Reduction Act from President Biden that forces the drug companies to negotiate a limited number of drug prices for Medicare payment. And this is an article that appeared a month ago in the Washington Post, how Big Pharma is fighting Biden's program to lower seniors' drug costs. So the drug industry has dug in, and they're going to try to undo the progress that's been made in controlling the drug prices, even in a limited fashion. So in a flurry of lawsuits, these drug makers have blasted the government initiative as unconstitutional, defending their pricing practices, and warned that regulation could undermine future cares. Remember that. They've said it a different way. They said it's going to be a nuclear winter for drug development, even as millions of older Americans say they are struggling to afford their essential treatments. This program this is a lawyer for Janssen. This program would have a debilitating effect on plaintiffs' ability to compete, and innovate, said Kevin King, a lawyer for Janssen, which makes Xarelto an anti-blood clot medicine, which is subject to negotiation. So they're crying like stuck pigs that they're not going to be able to develop new drugs, and that the curtailment of their profitability is going to be a disaster for American healthcare. Now, the CBO is the Congressional Budget Office, and they are an extremely trustworthy organization whose job it is to take new legislation and calculate what the consequences of the new legislation will be. So the drug industry says it's going to curtail their drug development and it's going to curtail availability of new drugs. The CBO estimated that negotiations will reduce the deficit by $25 billion in 2031 through decreasing the cost for Medicare Part D, Medicare Part B in a hospital and doctor's office, administration of drugs, and other federal funding. $25 billion in 2031. In 2031, a guesstimate of what the drug costs will be is $900 billion. So what the drug industry stands to lose is 25 billion out of 900 billion. That's 0.25%. It's minuscule. And the CBO estimated that over the next 30 years, 13 fewer drugs of 13,000 estimated new drugs will come to market as a result of the law. 13 fewer new drugs. But remember, only 1 out of 4 new drugs is actually materially better than therapies that are on the market already. So we're talking about not having access to 3 new drugs over 30 years in order to do limited negotiations with the drug companies. And it's important to keep in mind, this is a really important case in point, because the drug company's job is to maximize their profits. It's not to maximize their profits while they optimize Americans' health. It's to maximize their profits. And if they're going to lose $25 billion in 2031 because of this legislation, even though that's a drop in the bucket, and there are going to be 3 fewer new drugs over 30 years, they're going to fight it. They're going to dig trenches and try and prevent that healthcare reform from coming forward.